This is my last talk, and we are going to review the presentation of the long QT during the prenatal time and the management of those pregnancies. But before we go to look into the affected by the long QT, I would like to remind you this is the ultrasound-based techniques for the fetal arrhythmia assessment. So I think that the assessment of the cardiac rhythm is one of the most challenging tasks, in particular if you work at the MFM settings, because this is very different from just looking at the structural anomalies. And here I want to demonstrate the ultrasound-based techniques that can be used for assessment of the rhythm. So the main principle that you need to follow, that you need to achieve the simultaneous registration of two traces corresponding to the atrial and ventricular contractions during the cardiac cycle. Unfortunately, we cannot look specifically at the electrophysiological events that are happening in the fetal heart, because that would require the fetal electrocardiogram, even though that method is dramatically improved over the last decade. But still, the cheap and the most accessible method of assessment of the rhythm is still ultrasound nowadays. So, of course, then we are looking at the 2D image. Just visualization of the heart doesn't really allow us to judge what type of the arrhythmia we are dealing with, but this is a good starting point to apply all the other techniques that we have available to figure it out what's specifically going on with the fetal heart. And one of the techniques that probably the oldest in the fetal echocardiography, this is the M-mode method. Then we have the M-mode cursor placed across the ventricle and the atrium. It could be left and right, it doesn't matter, but this is the technique that allows to direct visualization, the atrial contractions, so atrial mechanical events, as you can see on the bottom, and also the mechanical events following the atrial contractions in each cardiac cycle, and this is the ventricular contractions on the top. So if the baby is not in a very favorable position, so babies behave the way they want, right? So that we have an advantage of changing the angle of the cursor, and that would allow us to get the better trace. And in particular, because the mechanical activity of the atria is usually very difficult to trace, so that would improve the visualization of the atrial contractions that you can see here. And finally, we can apply two cursors if the system has that opportunity, that can be applied on the atria and the ventricles, and this is the perfect technique. Then the four-chamber view demonstrates that axial orientation, because then the cursor applied across the borders of the cardiac chambers, and we can actually visualize the maximal amplitude of motion of those chambers. So that makes the tracing really improved, and you can clearly see and read those contractions from the atria and from the ventricles, which are very conveniently highlighted by the color of the lines that we are applying here. And of course, they are pretty much associated with time, so that we can see each atrial contraction followed by ventricular contraction, and easily can predict and describe this rhythm as the one-to-one conduction consistent with the sinus rhythm. Let's say if you perform the scan that visualization is not great, and you deal with a very morbidly obese patient or just difficult patient because of the some interventions on the abdominal wall. So you may combine the 2D images to the color images, and here we can see that the M mode applied across the left ventricle and the right atrium, and then we applied color. We will be able to see here the flow during diastole, then it has the early diastolic feeling and the atrial contraction, and this is the time then the mitral valve is open, and then we catching the blood flow in the left ventricle outflow tract, that is injection to the aorta, and that would correspond to the ventricular contraction. So here the brighter area at the end of the diastole, usually the atrial contractions, and this is how we can identify those contractions and identify where the atrial and ventricular mechanical events, and see if there is any correspondence between them. But of course, the spectrodoppler techniques, they are also very helpful for us. And here we can see, first of all, the technique that also utilizes the convenient anatomical orientation on the inflow and the outflow in the left ventricle, where we can open up the gate and place the sample volume of the spectrodoppler like this, and we will be able to see the inflow, early diastolic flow, E wave, and the A wave that corresponds corresponds to the atrial contraction, and then the ventricular contractions we will visualize as the injections to the aorta. So here we can clearly see the clicks of opening and closure of the mitral and aortic valves. You can see those linear structures here that also can be very helpful in determination of the different phases within the cardiac cycles and measurements of the PR intervals. So another Doppler technique that also was proposed as the first method using the spectral Doppler. This is simultaneous visualization of the blood flow in the superior vena cava and the ascending aorta. Unfortunately, if you look at those early papers, they are not really using very standard planes, so that makes the application is quite difficult, and also the superior vena cava usually doesn't really have the reverse flow or absent flow during atrial contraction, so that's why sometimes it's very difficult to identify where the atrial contraction is in the venous tracing. So that's why, as we demonstrated yesterday, it's more convenient and easier to apply the technique than you utilize the spatial relationship between the left brachiocephalic vein and the aorta. And in the left brachiocephalic vein, you usually have the reverse flow during atrial contraction that helps you to identify those below the baseline, like on this trace, very clearly. And then, of course, the blood flow in the aorta demonstrates the ventricular activity. So, and here we can confirm, and it's very important to confirm that each atrial contraction followed by ventricular contraction. So the same principle can be applied. Then we are looking at the vessels of the lungs, and this is the technique proposed by Dr. Giulini Carvalho from London. So here we can utilize the very close relationship of the pulmonary artery and vein, and the pulmonary vein will demonstrate that typical triphasic flow, that we have the flow during systole, early diastole, and then reduction of the velocity during atrial contraction. That helps us to identify where the atrial contractions are, and of course the blood flow in the pulmonary artery branches will help us to identify the ventricular mechanical events. So this is a very easy to obtain, especially if you're looking at the heart and other positions are not really that convenient. So we tried yesterday to achieve the renal artery and vein assessment for arrhythmia to demonstrate that technique. This is probably the technique that is the most useful late in the third trimester, and you know that after 30 weeks we have just a flood and tide of the referrals because of the fetal arrhythmia consistent usually with ectopic beats. So then the visualization of the heart itself could be very difficult. So here we can utilize the a relationship of the renal artery and vein, and we can obtain the trace like that. And again, the principle is the same. We are looking at the atrial contractions on the venous flow, and we look at the ventricular contractions in the arterial flow. So, and finally, the tissue Doppler technology that we were able to demonstrate yesterday. So here we have the trace, and again, we usually apply spectral Doppler gate on the tricuspid annulus, at the lateral aspect of the tricuspid annulus, like for the measurement of the other parameter, like TAPSE. And then we will get the trace that demonstrates the ventricular contraction, so systolic motion of the myocardium. And then we can see two biphasic diastolic motion, meaning that this is a motion during early diastole and this is motion during atrial contraction. So, and this is how we can identify, again, each atrial contraction followed by ventricular contraction. And if you work in the pediatric cardiology settings and you have more sophisticated techniques such as the color-coded tissue Doppler echocardiography, so you can actually add a lot to the differential diagnosis of different arrhythmias. And I would like to highlight this paper from Dr. Hornberger group from Alberta, Canada, that applied this technique for differential diagnosis of different arrhythmias. And as you can see from the title of the paper, they believe and prove that there is an incremental benefit of using this technique for differential diagnosis. So here we have two areas of interest. One is applied to the myocardium of the atria, and another one on the myocardium of the ventricle. And you can get the trace pretty much, in appearance similar to electrocardiogram. But what you can see here green is the trace from the atria and the yellow from the ventricle. You can see that then the atrium is contracting, so the ventricle is relaxing. So that this is like the opposite movement of the muscle of different chambers during that time. But we can clearly identify the activity of the atria and the ventricle in two different traces simultaneously and associated in time. So that could be really, really important for differential diagnosis. And this technique, if you have ability and access to equipment like that, so really expands our ability for differential diagnosis of arrhythmia. And so here is just another reminder that it makes sense to measure the heart rates separately for the atria and the ventricles in 2 consecutive cardiac cycles, and this is what we usually implement in our department. So now then we know our tools, we know how well we are equipped with all this ultrasound technology, so we are ready to apply all this. And this is a patient that was referred for fetal echocardiogram at 23 weeks and 3 days. That was her first pregnancy, no complicating factors. She declined all the screening. And so the suspicion was for bradycardia on her morphological assessment in the mid-second trimester in her doctor. So the fetus was in the bridge presentation. Here you can see the 4-chamber view that clearly demonstrates normal appearance, 2 atria, 2 ventricles, you are eyeballing structures, and it seems that everything is okay. So we added the color Doppler. Again, all the normal anatomy is confirmed. We can see the normal drainage of the pulmonary veins, normal contractility. So looks everything is okay. But what really catching the eye that, the baby's heart rate is a little bit lazy. Right? I think that you can see that. So then the baby moves around, it's supposed to be some kind of acceleration, deceleration, but baby kind of sleeping all the time, and the heart rate is nice and regular, but not really high enough in terms of rate. So we were observing that for quite some time. We obtained all the views which are necessary to complete the fetal echocardiogram. You can see that the outflow tracts showing no problems. The 3 vessel and trachea view, again, in 2D and in color look perfectly normal. And then we measured the heart rate at the beginning of the exam. It was 114. Then we measured that at the end of the exam. It was 118. And during the entire scan, then we spent about 45 minutes with that patient, because we did also the assessment of the baby and detailed assessment of the anatomy of the baby. So the heart rate never crossed the limit of 120 beats per minute. The average being around 115. So that was very concerning. So then we took the patient to the consult room and we asked her extensively about any family history of sudden cardiac death, of any issues on the electrocardiogram, any episodes of syncope. Then she was young, so none of this was actually positive, but she did admit that then she was young. She went to Mayo Clinic and she suffered from anorexia, and she had some changes on her electrocardiogram. So we also measured the PR interval that was within normal limits, and here you can see that we brought that patient back several times during the pregnancy, and this is like the normal distribution of the heart rate within the normal pregnancy, and all this red stars demonstrating the average heart rate, and we measured the heart rate at least 5 times during the exam each time. So that was like barely above the cutoff for the clinical definition of the fetal bradycardia, which is 110 beats per minute. So the situation was discussed with her OB provider, and they wanted to keep her with them for delivery, thinking that it's going to be just okay and they can handle it. So that was our concern. We confirmed that the baby has the subclinical sinus bradycardia with the suspected long QT syndrome potentially. So, and of course, patient delivered outside, and so baby was normal birth weight, normal Apgars, but about 10 hours after delivery, baby developed the episode of severe bradycardia, the heart rate in 40s, and was transferred to the Children's Hospital, and on the electrocardiogram, the long QT syndrome was confirmed, and then the patient was placed on medication, the heart rate was stabilized, and then genetic testing was performed, and for sure this fetus and that newborn was a carrier of the special mutation, making the diagnosis consistent to long QT type 1. So then the mom was tested and her father was tested, and as a result of this suspicious on the fetus, and here is the postnatal electrocardiogram where you can see that the QT was significantly prolonged. So the entire family actually was diagnosed as a long QT, and all of them were placed on medication to prevent a sudden cardiac death. And so this is the grandfather and this is the mother, and they were featured in one of the magazines of our children's hospital. And since then, she had another pregnancy also affected by long QT, because as you probably understand here, that the inheritance of the long QT is autosomal dominant. So this is how the very careful evaluation of the fetal heart rate prevent potentially multiple family members from the very fatal consequences of having this inherited mutation. So what is the long QT syndrome? This is a cardiovascular disorder that pretty much characterized by the abnormality of the cardiac repolarization, leading to the prolongation of the long QT. And it's commonly associated with different clinical symptoms, but what is really important that those patients have a very high risk for the sudden cardiac death. It's relatively common. It accounts about 1 in 2,000 individuals. Again, the inheritance is autosomal dominant, so every time that each pregnancy, it's 50-50 chance that the baby gonna have it. And about 10% of those cases occur de novo. So you can see that so far there are 17 types of the long QT syndrome caused by different genetic mutations, and nowadays we have the whole panel available to test for those conditions if there is a suspicion of that. So, and you can see that all those genes, they are pretty much responsible for the proteins which are involved in the gates and channels which are presented at the membrane of the myocyte and regulated the current of the different ions such as the potassium and calcium and sodium. So out of these 17 different types and multiple gene mutations, so there are 3 most common, and they are presented here, and they account about for 80% of all cases of the long QT syndrome. If you look at them in more details, you can see that the most frequent is the type 1, the same that our child in this case was diagnosed. And type 1 and type 2, they are pretty much associated with the loss of function of that channel, preventing the current of the potassium at the late stage of the potential acting potential. So, and here you can see that the medication could be quite different even within these 3, and so that the onset and the symptoms, they also may vary significantly, because if you look at the long QT type 3, actually that is less common, and that associated with the gain of function, and that affects the channels regulating the current of sodium. So because of that heterogeneity in the condition, so the presentation prenatally could be different, and what's the most important, the outcome after birth can be very different. And there were several studies looking at the fetuses presenting to the different types and confirmed types within the families. There's a long QT, where you can see that actually long QT type 3 is the most dangerous and has the highest association with the fetal demise prenatally and the possibility of the sudden cardiac death in infancy and in the long-term time. So that's very critical to identify the specific mutation that the fetus has. What can we see on the prenatal echocardiogram that potentially can make us think that this is a long QT? First of all, this is a presentation as discussed in our case. So this is sustained borderline bradycardia. Then baby shows some variability in the heart rate, but this is a very narrow range of the heart rate going from usually 110 up to 125. So on the tracing, we also can look at the time after the closure of the aortic valve and before the opening of the mitral valve. So this is isometric relaxation time, and here you can see that that time is significantly prolonged in the patients with a long QT syndrome. So here there are several documentation of that phenomenon, and there is a hope that then we have a patient with the sustained sinus bradycardia. We need to pay attention to that parameter, and ideally that will help us together with the heart rate to identify those patients who are in a high risk for long QT, offer them testing, and that would result in improvement in the prenatal diagnosis of this condition. So what are the other risks of the mothers with the long QT syndrome? So it was the data published from the multi-center study that included 148 pregnancies from 103 families, and they were like origin of long QT was also documented. So what the study found, that despite of the status of the fetus, if the fetus has a long QT mutation or not, so this pregnancy in a high risk of incidence of the stillbirth and miscarriage. And the incidence of stillbirth is 8 times and miscarriage is 2 times greater than in general population. So that makes that really concerning. So also it's very interesting that the outcome of the pregnancy actually depends on the status of the mom. So if the mom doesn't have a long QT syndrome, so that the risk is not that increased. But if the mom does have the long QT syndrome, so then regardless of the status of the fetus, this pregnancy has a very high risk. So what was suggested, that those patients should be under very increased surveillance, in particular in the 3rd trimester of the pregnancy. But here you also need to remember that the non-stress test is going to be very specific, and we need to avoid any intervention that would result in some effect on the fetus. So you need to understand that the heart rate is supposed to be relatively low. Also, what this study showed, that the placement of the pregnancy is affected by the long QT on the drug therapy, actually improves the outcome for the fetus, and in particular improves the birth weight. So this is also something to keep in mind. So wrapping up on the long QT syndrome, this is the most common fetal presentation of this syndrome will be sinus bradycardia. So also the family history should be obtained, and usually if there are multiple family members who affected, it could be different symptoms, but it needs to be very carefully evaluated. So the long QT syndrome pregnancy should be considered at a high risk for the fetal demise, and that risks probably very carefully should be discussed with the patients. We need to make sure that we increase the surveillance of the fetal well-being, and as our case showed, so the delivery for that cases should be arranged in the specific institutions like where you have the cardiology services available and neonatal electrophysiology and postnatal genetic testing available. So in the last 5 minutes, I would like to briefly review the differential diagnosis of the long QT with other types of the sinus bradycardia. So in the sinus bradycardia, once again, based on the obstetrical definition, this is the fetal heart rate less than 110 beats per minute over the time of 10-minute period. So, and here is the case. So we have the 23-weeker, exactly the same gestational age. Fetal has severe growth restriction, less than the first percentile, and very severe cardiac anomaly. So that was an intermittent sinus bradycardia that was actually recognized as the signs of the fetal distress and should not be mistaken as some kind of true rhythm disorder. So this is another example, 36-weeker, poorly controlled pregestational diabetes. I was called at this very old case. It was in 2009, so suspected heart block. If we look at this heart, it looks very heartbreaking because basically this is just severe hypertrophic myocardial hypertrophy, mostly due to the very poorly controlled diabetes. And again, it has nothing to do with the rhythm issue. This baby is just simply dying. And during the ultrasound exam, so unfortunately we had the cardiac arrest and she was delivered in 5 minutes. Baby was resuscitated and kind of make it for the first few days and then unfortunately passed away. So this thing is actually you can observe the sinus bradycardia, but this is here you should act right away in delivery and don't really trying to figure it out what type of arrhythmia is that, right? So another case, we saw that yesterday this patient has a bradycardia. As you can see here, ventricular contraction, atrial contraction, so 104, very sustained, pretty much no variability. But let's take a look at this heart in a little bit more details. Okay, so here we have normal 4-chamber view, a little bit of tricuspid regurg, but behind the left atrium we have the double barrel sign. So what do we need to do? We need to take a very good look at the fetal situs, and for sure looking at the abdominal circumference, we saw this picture yesterday. This is a very mild form of left heterotaxy, left isomerism, and those fetuses, they have the issues with the conduction system of the heart, and in particular in this case, after birth, we diagnosed the weak sinus node syndrome. So also that fetus had severe malformation of the brain, consistent with the India worker malformation, and the neurologist after birth actually speculated that such a significant enlargement of the posterior fossa and that fluid collection also kind of compressed the brain stem, and that could be some result to the very slow heart rate, like that was the from central influence. So that was very interesting. So what else can be mistaken the sinus bradycardia? This is frequent blocked PECs by Gemini. So then every other contraction is ectopic, and that contraction occur way too close to the normal contraction. So that would result in significant bradycardia, usually between 80 and 100 beats per minute. So this is the patient who was presented with the bradycardia relatively early in the pregnancy, and you can see that the ventricular rate is very slow, 78. But if you look at the atrial rate, you can see every other contraction is ectopic. So then we followed that pregnancy alone, and for sure, in the third trimester, patients started to develop this very fast heart rate, where we had the episodes of normal heart rate, and that the episode of tachycardia would start, and you can observe those paroxysmal tachycardia very clearly. So this is the Gemini, then the tachycardia starts, then ectopic beat occur, and it kind of converts again to the abnormal irregular rhythm. So the patient was administered digoxin. We achieved the stable heart rate between 110 and 124. And the patient was delivered, and surprisingly for us, we had the follow-up on that patient very carefully and very frequently during the first 3 months. And then now the patient is 5 years old, no arrhythmia ever since. So, and this is just a contrast, the other patient that also presented pretty much the same findings, the ectopic beats, and they were also by Gemini. You can see here the heart rate is 83. So, and you can see that this patient had normal heartbeat and then 2 back-to-back ectopics, and that resulted in relatively slow ventricular rate. And you can see it here very clearly. It was sustained between 21 and 24 weeks gestation, and then by 27 weeks gestation, it magically resolved without any therapy or anything being done. So, and this is the course of that pregnancy, and then the patient delivered, and few hours after birth, that fetus had the SVT and was diagnosed with WPW syndrome. So this is just the overview of the management options of the irregular heartbeat and rhythm, and in particular blocked PVCs and PVCs. And you can see that about 1% of those cases may develop tachycardia, so you have to keep an eye on them very closely, but they should be distinguished from the long QT. So in here, I would like to thank you for your attention. It was a pleasure to be here in the last 2 days, and I hope to see you in the future. Thank you very much.